Hello, my name is Izolde Bouloukaki. I'm a general practitioner and somnologist, expert in sleep medicine at the University of Crete, School of Medicine in Greece. Welcome to this lecture. What I'm going to talk about today is screening tools for sleep-breathing disorders. During my presentation, I will address three crucial questions that must be answered in order to screen for sleep-breathing disorder: why it is important, who should be screened, and how the screening should be conducted. Let me begin by explaining why screening of sleep-breathing disorder is important. Sleep disorder breathing encompasses a broad spectrum of sleep-related breathing disorders, including obstructive sleep apnea or otherwise OSA, central sleep apnea, as well as sleep-related hypoventilation disorders. OSA is the most common sleep-related breathing disorder associated with significant morbidity and mortality. Treatment improves outcomes, and these features make OSA an ideal candidate for screening. However, OSA is under-recognized and under-treated, especially in minorities. In primary care practice, even though 1/3 of patients had high risk of having OSA, most patients had not discussed their sleep-related problems with their primary care providers. A major issue is that primary care providers usually do not elicit sleep-related symptoms from their patients. We can't also ignore that an online OSA patient network showed that 65% of the responders reported a diagnostic delay of more than 2 years. Next, we'll turn our attention to the question of which individual should be selected for screening. The U.S. Preventive Services Task Force neither supports nor rejects screening of asymptomatic adults for OSA. Nevertheless, this statement shouldn't give the wrong message to clinicians who try to identify a large population of symptomatic patients and patients who are not aware or do not report symptoms. In contrast, the American Academy of Sleep Medicine recommends the routine health visits should include questions about OSA and evaluation of risk factors, including obesity, cardiovascular and metabolic diseases, retrognathia, and associated symptoms such as snoring and excessive daytime sleepiness. Another important aspect to take into account is that the clinical guidelines for OSA evaluation and diagnosis are primarily derived from studies conducted with male patients. However, the clinical spectrum of OSA currently exceeds the traditional presentation of the male, obese, and sleepy patients outlined in scientific literature. Different clinical presentation phenotypes have been identified, such as the disturbed sleep group experiencing insomnia-related symptoms, the excessive sleepy group, and the minimally symptomatic group. Another key factor to consider is the difference in clinical presentation of OSA between men and women, which can complicate the screening process for women. The reason behind this is that the female phenotype is less clearly defined, as women with OSA predominantly present non-specific symptoms such as insomnia, depression, fatigue, morning headaches, and nightmares. Therefore, making a diagnosis of OSA in women might be more difficult compared to men. Other patients at risk for OSA that need to be screened are patients with respiratory diseases with specific focus on COPD, idiopathic pulmonary fibrosis, and asthma, and endocrine disorders such as diabetes type 2. Screening for OSA is also strongly recommended in commercial motor vehicle operators, preoperative patients, and pregnant women, as well as in patients with resistant, poorly controlled hypertension, pulmonary hypertension, and recurrent atrial fibrillation, either after cardioversion or ablation. If concerning signs and symptoms of sleep apnea are present in patients with heart failure, stroke, arrhythmias, and survivors of sudden cardiac death, a formal sleep assessment is reasonable. OSA is also often undiagnosed and undertreated in professional drivers. Professional drivers often underreport and are reluctant to report OSA symptoms. Therefore, screening tools may assist in early identification and appropriate referral of possible OSA among professional drivers. Next, we will explore the appropriate approach to screening for OSA. Once we have identified the population at high risk for OSA, it is important to utilize appropriate screening tools. Potential screening strategies include formal screening questionnaires and clinical prediction tools that include various combinations of subjective and objective findings. For persons who screen positive, a diagnostic test would be used to determine whether they have OSA. The ideal diagnostic screening tool should include a few items, be easy to administer and interpret without the need of complicated calculations or examination techniques. A number of clinical questionnaires have been developed to predict the presence of OSA based on symptoms, for example, excessive daytime sleepiness, anthropometrics such as body mass index, neck circumference, demographics such as gender and age, and the presence of comorbidities such as hypertension or stroke. However, a high sensitivity with an acceptable specificity is a basic requirement for screening patients for a disease with an important health impact such as OSA. The sensitivity and specificity of OSA screening tools have demonstrated considerable variability depending on the patient population and the definition of OSA. The following instruments for assessing OSA risk are freely available, brief, self-administered, and well-validated. These include the Epworth Sleepiness Scale, the Berlin Questionnaire, the Stop-Back Questionnaire. The Epworth Sleepiness Scale is currently the most used subjective test of daytime sleepiness in clinical practice. It is a simple, self-administered, 8-item questionnaire that measures the risk of falling asleep in 8 specific situations that are commonly met. However, Epworth Sleepiness Scale score has low sensitivity for OSA and does not always correlate with OSA severity, because even patients with severe OSA may have relatively mild daytime sleepiness or even be asymptomatic. The Berlin Questionnaire, developed for use in primary care settings, has demonstrated a moderate level of accuracy with moderate to high sensitivity and a specificity that was low to moderate. The Stop-Back Questionnaire, developed for preoperative screening, is an easy-to-administer OSA screening tool. Using the acronym STOP, meaning snoring, tiredness, obstructive apnea, and high blood pressure, and the BANG, meaning body mass index, age, neck circumference, and gender, makes it easy for clinicians to remember. If the individual scores positive with at least 3 questions, the patient is found to be at high risk for OSA. It has been used extensively in various populations with adequate sensitivity and diagnostic accuracy for detecting moderate to severe OSA. Another simple, effective, and practical tool that identifies those at risk of OSA has recently been proposed as a screening tool. Using variables easily available in clinical practice, neck circumference, obesity, snoring, age, and sex, the NOSA score allows clinically significant OSA to be reliably ruled out. Patients have a high probability of OSA if they have a NOSA score of 8 or higher. Other means of assessing OSA have been investigated, such as nocturnal pulse oximetry, which is portable, economical, widely available, and simple to use. Having a 2-step process with patients screened first with a comprehensive sleep history along with sleep questionnaires and then by oximetry could increase preterm probability of OSA and prioritize high-risk patients to sleep center for diagnostic study. In conclusion, let me briefly summarize the main points. Although OSA is a prevalent disease with significant morbidity and mortality, it remains underdiagnosed and undertreated. They are safe, simple, quick, low-cost, and easy-to-administer questionnaires, with some of them exhibiting good specificity and sensitivity. 2-stage screening, combining questionnaires and home monitoring devices, seem more accurate. This screening may be initiated in certain high-risk groups. If a patient is just high risk, this might then trigger a move directly to confirmatory diagnostic testing. We currently do not have enough direct evidence to support the notion that screening for asymptomatic OSA has a positive impact on important clinical outcomes. Additionally, we have insufficient high-quality evidence concerning the sensitivity, specificity, and positive or negative predictive values of the proposed screening tools. However, keep in mind that in OSA screening area, we are still in the search for the holy grail, so further research is needed. The assessment that follows will test you in screening questionnaires, particularly the Stop-Back and NOSAs, and in interpreting the findings to identify individuals who may be at risk for OSA. You have to score Stop-Back and NOSAs questionnaires and identify if the following patient is at high risk for OSA based on their scores. The patient is a 45-year-old man referred to the sleep center with a long history of loud snoring, witnessed apneas, and excessive daytime sleepiness. The physical examination shows a BMI of 32 and his neck is 46 centimeters in circumference. The patient had no significant past medical history or comorbidity. Thank you so much for your attention.